I was asking that what should I talk, and when I knew that it is basically the presentations for the DNB students from all over India, so we discussed and we decided that let us talk something which will be helpful for our students, DNB students, to appear for their exam. So we discussed that I'll be taking another lecture. I don't know, I'll be trying to complete as much as what I have written here. So in the subsequent slide, these are the topics and these are the questions which might be there. One question might be define pain and describe pain pathway. It might be 10 or even 15 marks might be there from this question. Another very might be there that what is pain modulation and how antidepressant works. Describe different types of modulation in detail, pain modulation in details. So this can be the another question. Classify different types of pain, and amongst the different types of pain, one very important type is neuropathic pain. So what are the clinical features of neuropathic pain? And there might be some short notes like gate control theory, what is segmental inhibition, what is descending inhibitory pathways. So these might be the short questions, maybe might be carrying around 4 marks or something like that. So these are the topics which I'm going to cover today. The next day I'll be talking about the neural plasticity, the central sensitization, peripheral sensitization. These will be my topic on the next day, maybe next Friday, I don't know exactly. So today I'm going to cover these topics, and now these might be the possible questions, and these might be the possible marks for these questions. So if you are listening nicely, you will be able to answer these questions nicely, I hope. So let us start with the definition of the pain. So who can, from these DNB students, who can define? Do you remember that the recent changes in the ISP's definition? Earlier, the definition was that pain is an unpleasant sensory and emotional experience associated with actual or potential damage or described in terms of such damage. This was earlier definition. But very recently, the described in terms of such damage has been deleted, and in that place, the few words are added resembling that associated with. So this made the confusion of the earlier definitions very clear. And from the definition, we can understand that pain is always unpleasant. Nobody like to have the pain. Second important component of this definition is pain is not just a sensory feeling. Pain is also an emotional feeling. Pain hurts us physically as well as the pain hurts us emotionally. And that is the reason when we are assessing the pain, there are if you are getting talking about the how to take the history. So very frequently we talk these things, how to assess pain intensity. So there are 2 types of pain scale. One which assess only the physical amount of the pain. That is called unidimensional pain scale. Like all of you know that visual analog scale, the numeric rating scale, verbal rating scale. So all these are faces rating scale, looking at the face. So all these are basically the unidimensional pain scale. What's the meaning of that? That these pain scale are basically enabling us to assess pain, how much it is hurting physically. That means it is the sensory component of the pain which can be assessed with these tools. But very important is the second component. What is that? That emotional component. Pain hurts us emotionally as well. I'll be describing it how it is hurting emotionally, and that is the reason why the ordinary pain scale, like visual analog scale, like the numeric rating scale, they are not enough to assess how much pain is hurting emotionally. And for that, we need a multi-dimensional pain scale. So there are a few multi-dimensional pain scale. One of the very important multi-dimensional pain scale is your McGill's pain questionnaire. So this McGill pain questionnaire, it assesses pain, how much it is hurting physically, how much it is hurting emotionally, how much is the the cognitive functions. Pain also, here it is not mentioned, but pain also changes our cognitive functions. It affects our cognitive functions. So McGill's pain question also assess the cognitive functions, derangement of the cognitive functions. So coming back to the definition, if it is asked, if this question is asking, define pain and explain the definition of the pain. So we need to tell that pain is an unpleasant sensation. Pain hurts us physically as well as emotionally, and it is either associated with, it is due to actual tissue damage or potential tissue damage. What is potential tissue damage? Potential tissue damage means the disease might be in incubation period. The disease process, pathological process has started, but not yet fully expressed. So that is your potential tissue damage. So it can be because of the actual or potential tissue damage, or it might be resembling actual potential tissue damage, but in reality there might not be having any tissue damage. We'll be discussing this part next day when we'll be talking about the neuropathic pain and other type, when we'll be talking about the sensitization. So remember that we have always learned these things, that the pain is associated with tissue damage, but the definition itself tells that there are certain kind of pain where the tissue damage is not needed. There are some other mechanism of those kind of pain. So now will be today the main area what we will be discussing is your pain pathway. And pain pathway classically has been divided into 4 areas. One is transduction, second is transmission, third is perception, and fourth is modulation. So we'll be discussing one by one all these 4 important areas. First is I'll be going straight into this schematic diagram. This diagram is anatomically not correct. It is, and it is not very good drawn by myself. So so don't try to relate the thing with the real anatomy. It's just a schematic diagram. So first part is, so can you please mute?
Pretty much see this there. Don't go through all that trouble. You can also just for quick time up here or up here, right here. So you can go in.
Hello.
So now what you want to do, click on File, and you want to click on Screen
Recording.
So
I request you please unmute mute.
Participants, kindly mute yourself. Participants, kindly mute yourself.
I request once again to you all, please mute yourself. Thank you, sir.
Okay. So what I was discussing, that the pain pathway can be described into the 4 important areas. One is transduction, second is transmission, third is your perception, and fourth is modulation. We all know these things, and I'm not going to the detail of all the things. I'll be just discussing about the area which has not been covered nicely in our undergraduate postgraduate study. So first part is your transduction. What exactly is the transduction process? Transduction means it is the transformation of the energy. 3 kinds of energy. 3 kinds of energy converted into the action potentials of pain. Pain action potentials is basically a form of electrical energy. So this electrical energy can be, a lot of noises are coming. I am requesting host, please mute everybody. Hello, can you all mute it?
Yes, sir. I have muted all, sir.
Okay. So okay. So transduction means it is the transformation of one kind of energy into the electrical energy. So three kinds of energy can be converted into the action potentials. So what are those three kinds of energy? Number one is your mechanical energy, number two is the thermal energy, and number three is chemical energy. So basically these three types of energy, basically we call it as a noxious stimuli. So in that stimuli, so there are three kinds of stimuli. It can be a chemical stimuli, it can be a thermal stimuli, it can be a mechanical stimuli. So these three kinds of energy is converted into the electrical energy or action potentials, and the process is done at nociceptors. So these nociceptors converts this kind of energy and they create action potentials, and this process is known as transduction. So there might be the short note on transduction as well. For the DNB students, I have written some of the short notes. So the transduction can be a short note. So it's you have to tell that three kinds of energy are converted into action potentials: mechanical, mechanical, chemical, and thermal. So when they are crossing the threshold needed to create action potentials, then action potentials are created, and it is at the three nerve terminals, and then it is carried over the first order neuron, second order neuron, third order neuron. This is called transmission. And in this transmission process, you all know there are two kinds of nerve. One is non-myelinated C fiber, where the transmission process is slow because it is a non-myelinated nerve. It is also called the slow transmission, slow pain. And another transmitted by the A delta fiber, which is myelinated, where the transmission process is faster, and it is also called the fast pain. So the two types of nerves: first order neuron, second order neuron, third order neuron. First order neuron from periphery, from the areas where the action potentials are generated, from there up to the dorsal horn, and then from the dorsal horn, second order neuron, mostly it goes to the spinothalamic tract and ends at thalamus. And from thalamus, third order neuron is sending signal to the post-central gyrus. We all know those things. But what we need to know, some other things we need to know. That in the higher center, there are not just the sensory cortex, nor the post-central gyrus. And it has been proved by the fMRI studies. So these MRI studies was taken when somebody was having the very severe intense pain, and then this fMRI is showing that the four important areas of the brain are getting stimulated. What are those? Apart from the post-central gyrus, there are different limbic nuclei scattered in the different parts of the brain. So limbic nuclei are also stimulated. Reticular network, reticular formation is stimulated, and periaqueductal gray matters are stimulated. So the higher centers, the different areas which are stimulated, can be grouped into the four different types. And coming back, so these four different types, apart from the post-central gyrus, the most important area is your limbic nuclei, not nucleus, because limbic nuclei are scattered in the different parts of the brain. And what are the functions of the limbic nuclei? They control our emotions. So if we are looking back about the definition of the pain, what is pain? Pain is an unpleasant sensory and emotional experience. So you have to always remember, pain do not just hurts us physically, pain also hurts us emotionally. And this is the physiological explanation. So the third order neuron, the fibers are not just reaching the post-central gyrus, it is also reaching the different limbic nuclei and causes the emotional changes. So we feel sad, physically hurting, but also mentally hurting. The pain also hurts us mentally, emotionally. Then third important area, what is that? That is your reticular formation. What is the function? It keeps us awake. And if you're remembering, in your student life, that your friend in your roommate is sleeping and you are calling, is still not, then you are pinching. What will happen? He will be jumping. So the pain, and even in your clinical practice also you have seen in the post-operative period, if the pain is not taken care, the patient cannot sleep. because the pain signal reaches the limbic nuclei and keeps us awake. So this is the third important area. And the fourth important area is your periaqueductal gray matter. So what happens? So signals are reaching to the opposite side. That means same side where the injury was there, periaqueductal gray matter, which are called descending inhibitory pathways. So I'll be sharing you one very in the our early 80s, late 70s, this period. So what was done in the experimental animal, external fluid was placed at the periaqueductal, and then the external electrolyte was sent and stimulated the periaqueductal matter, and then laboratory operation was done in those animals, and they didn't feel any pain. So later on, gradually it was understood the body's strongest pain inhibitory system is your descending inhibitory pathway. It starts directly through other nuclei by relaying to other nuclei. Ultimately, it sends signal at the level of the where dorsal horn, where the first order neuron was sending signal to the second order neuron. At that level, it suppresses. So here we have to remember a few neurotransmitters. Number one, here the periaqueductal gray matter, when signals comes here, the two important neurotransmitters are released. These are serotonin and norepinephrine. I told you one important question: how antidepressant work in pain? So this is the answer. So the signal reaches the periaqueductal gray matter of the same side of the tissue injury, and they release serotonin and norepinephrine. So this serotonin and norepinephrine activates descending inhibitory pathway, and then they send inhibitory signal where the signal first order neuron was sending signal to the second order neuron, and here they suppress. How they suppress? By releasing so that the pain it is pathway very strong. Improved by the animal. We have to remember that we suffer from pain. So body static mechanism always try to reduce our suffering. So how to do that? It should be utilized. It must be utilized the body's strongest inhibitory system. What is that? It is your descending inhibitory pathway. And how to stimulate it? By releasing serotonin and norepinephrine at the periaqueductal gray matter. So what will happen? Pain will be reduced. Imagine I'm suffering from a condition, chronic condition. For example, I'm having the osteoarthritis of knee. I'm having knee pain. No? First day, second day, third day, every day my body is trying to reduce my pain. Say for example, my pathological changes in the knee are same. Still, what will happen over the period of time, a few months? So this neurotransmitter stores will be depleted. This descending inhibitory pathway will be exhausted. So even though pathology was same, even then I will be suffering more pain, because earlier this was taken care nicely by this descending inhibitory pathway, but now it cannot, because the system has been utilized for long, and then gradually so same pathology is now going to create more pain. And now I have visited a doctor, a pain doctor, an anesthesiologist, and he have prescribed a drug which increases the level of serotonin and norepinephrine at periaqueductal gray matter. What will happen? So now descending inhibitory pathway, and it will be taking care of the pain. So what is the name of this drug? These are antidepressant. So if it is asked how antidepressant is going to help us in pain, particularly the chronic pain, what will be the answer? This is one of the very common myth. I'm talking myth because this is many times wrongly explained that these antidepressants are taking care of our depression, it is taking care of pain. No, this is not the answer. So this is why. Any proof? Very simple proof. If you are giving one of the commonest drug used to treat the example SSRI, selective serotonin reuptake inhibitor. You know, there are a long list of drugs like escitalopram, sertraline. So all these drugs are very commonly used for depression. But if you are giving it in the pain, it is not a good drug. Why? Because it is going to elevate only serotonin, no action on norepinephrine. So pain will not be nicely relieved. Another very important proof is there. If you're talking about the drug doses, say for example, you are using amitriptyline. Amitriptyline is one of the very common drug to take care of the chronic pain. So amitriptyline, if you are using to treat the depression, what is the antidepressant dose? Antidepressant dose of amitriptyline is 75 milligram onward, even 150 milligram. But what is the dose for the managing pain? Only 10 milligram, 25 milligram, even 5 milligram is enough. How? It is not reaching the antidepressant dose of 75 milligrams. Still, how it is working in pain? The explanation is, even at low dose, this antidepressant can be helpful. But which antidepressant? Is it SSRI? Answer is no. So you need to select the antidepressant where both serotonin and norepinephrine are elevated. Only serotonin is not going to be helpful. So both serotonin and norepinephrine are elevated by two important classes of the antidepressant. One of them is, the tricyclic antidepressant. So tricyclic antidepressants, example is your amitriptyline, nortriptyline, few others are there. So they are very good drug. But the problem with this drug is that they are having the strong anticholinergic side effect. So anticholinergic side effect like dryness of the mouth, the increase of the ocular pressure, then your the tachycardia, posteriorly, the postural hypotension, then your the retention of the urine. So there are a few bad side effects of the anticholinergic side effects of the tricyclics, and that is the reason when you are using tricyclics in an elderly population, we must be very careful, because the elderly, the patient might be having the prostate hypertrophy, the elderly person might be having the cardiac problem, so it can cause the arrhythmias. So all these things we have to take care. But another antidepressant class is there, which raises both serotonin and norepinephrine, but they are chemically are not the tricyclics. So they are called SNRI, serotonin norepinephrine reuptake inhibitors. SNRI. This class of the drug is also very important, and many of these drugs are US FDA approved for treating the different kinds of chronic pain. What are these drugs? One of them, most widely prescribed, is your duloxetine. So duloxetine is one which is elevating both serotonin and norepinephrine. Few others are there, the wellness vaccines like the milnacipran. There are a few other drugs which are also elevating serotonin and norepinephrine of this class. So SSRI is not a good drug for managing pain because it elevates only serotonin. But SNRI and tricyclics are very good drug. So it can be a question, how antidepressant drug explain the mechanism and how which antidepressants. So you have to take or talk all of this, and here you have to remember the descending inhibitory pathway is very, very important. Now we have already entered into the fourth area, that is your pain modulation. So modulation of the pain means, what is the definition of the pain modulation? So action potentials which is generated at the periphery because of the transduction and what is reaching here in the higher centers are not same. They are changed. So they either might be amplified or they might be dampened. So amplification of the pain is called sensitization. Today I'm not going to talk about the sensitization. I'll be talking in the next class about the sensitization. But other part, opposite part, is called modulation. That means, what is pain modulation? Means it is a natural suppression of the body. It is not a pathological condition. It is a feature of a normal healthy individual, that whatever the action potentials are generated and whatever the pain we are feeling, body tries to suppress it by its natural pain suppressing mechanisms, and that is your modulation. So the pain modulation, there are four important areas of the pain modulation. Number one, I have already described, descending inhibitory pathway. I already told that the descending inhibitory pathway itself can be a very important short note. You know, even long questions or 5-6 number question might be coming on descending inhibitory pathway. And if you tell all the details, starting from the periaqueductal diameter up to the dorsal horn, and starting point is by serotonin norepinephrine, and end there is opioid. So this is how it is working. Now the second important area, again very important. You know, I always tell one of the very important history in the pain management is this one. This is your gate control theory, and historical event is your the 1965. This gate control theory was published 1965. Remember this date? You know, it is one of my very favorite multiple choice question or any other question. Which year the gate control was first published? This is your 1960. Always written, you know, in the, you know, very instance to the gate is being controlled by thickness, you know, muscular. This instrument, the 85 is not close the gate. The signals cross the gate. Very simple. Stimulate the larger diameter fiber. Again, there is some noise. So what is it? The stimulation of the larger diameter A beta fiber will close the gate for the smaller diameter fiber signal, that means C fibers, so that, or A delta fibers, so that it is not crossing the gate to reach the second order neuron. So the question is, how is it possible? How is it possible? So if the larger diameter A beta fibers are stimulated at the gate is again, it is the dorsal horn, or the first order neuron is sending signal to the second order neuron. At this gate, there are certain inhibitory interneurons. So these inhibitory interneurons are stimulated by the A beta fiber, and inhibitory interneurons suppress the signal, do not allow the signals coming from the smaller diameter fibers to cross the gate. So the action potentials are not crossing the gate. This is your gate control theory. Gate is being controlled by the larger diameter fiber stimulation. You understand gate control theory? So now there are a lot of practical applications. Say for example, that suppose a child is having complaining of pain abdomen, and what will be her mother doing? Mother will be moving the hand on the abdomen, isn't it? And the pain is going to reduce. Pain is reduced because the larger diameter from touching, what is happening? A beta fibers are stimulated. A beta fibers are stimulated, so it closes the gate for the nociceptive C fibers. Now the question is very important: is suppose the child is having pain abdomen, and if the mother is moving the hand on the head, will the pain be reduced? Answer is no, because you have to close the same gate. If the pain abdomen is there, you have to move your hand on the abdomen to close the same gate. If you are closing the other gate, what will happen? This signal will be going. So this is one of the common applications, but two other important applications was there. As soon as this was published in 1965, in 1967, another very important, historical event, milestones. So that was spinal cord stimulator. I don't know how many of you, the DMB student, have heard about the spinal cord stimulator. Spinal cord stimulator is also called the spinal cord pacemaker. You have heard about the pacemaker, cardiac pacemaker. So what is done there? So there will be a small battery implanted under the skin, and from there electrode are cardiac chambers. That is the cardiac pacemaker. So what is a spinal cord pacemaker or spinal cord stimulator? Here also the same. A battery will be implanted into the skin and the electrode will be placed into the epidural space to stimulate. Stimulate which fiber? To stimulate A beta fibers. So it was first done by a neurosurgeon called Seeley. Though nowadays spinal cord stimulator is by us, pain physicians, anesthesiologists are actually implanting this nowadays. But first it was by one neurosurgeon Seeley. So we did a laminectomy and placed the electrode there, large electrode. Nowadays those electrodes are not used. Nowadays the electrodes are placed like epidural catheter. You put in epidural needle and through that you can pass the electrodes into the epidural space and connect it with the battery, and the battery can be implanted under the skin. And these are done by anesthesiologists mostly all over the world. So the spinal cord stimulator was first based on this gate control theory in 1967. So how it works? It delivers the current at a frequency. Again, one of the very basic question I'll be asking you. All of you are using the nerve motor stimulator, isn't it? So there is a contraction of the muscle. So at which frequency the current, first of all, is it an alternating current or direct current? Answer is, it is an alternating current. What is direct current? Direct current means two electrodes, current is flowing from one direction. That is your direct current. What is alternating current? The direction is changing. And how many times it is changing its direction, that is called the frequency of this alternating electricity. So direct current, alternating current are used to stimulate the nerves, and the frequency of the nerves tells us which fibers will be getting stimulated. So when you do a muscle contraction, twitching, at what frequency is deliver the current? It is 1 to 2 hertz, isn't it? Have you noticed it? It is 1 to 2 hertz current which stimulates the motor fibers. And some of the nerve motor stimulator, there is a setup where you can change it either 1 hertz or 2 hertz. And you have to remember that between 1 to 10 hertz alternating current, the motor fibers are getting stimulated. And to stimulate the A beta fibers, what is the frequency range? Simple to remember that smaller the diameter of the nerve, the higher the frequency is needed to stimulate. So motor fiber is thick fiber, so the stimulation range is your 1 to 10 hertz. Whereas A beta fibers, it is a smaller than motor fibers but thicker than the pain fibers. So here frequency needed is 20 to 40 hertz. 20 to 40 hertz. And pain fibers 50 to 100 hertz. Okay, so if we are placing the electrode there in the epidural space and delivering the current at a frequency of 20 to 40 hertz, what will happen? A beta fibers will be stimulated, and if the A beta fibers are stimulated, it closes the gate for A delta and C fibers, and that is the mechanism how this spinal cord stimulator works. Another very important clinical application, very widely used by the physiotherapists, physical medicine people, that is your TENS, transcutaneous electrical nerve stimulation. So what is done there? So there the cutaneous electrode placed on the on the skin is placed and again stimulated at which frequency? Direct current or alternating current? It is alternating current at a frequency of 20 to 40 hertz, which will be suppressing the pain signal coming via the A delta and C fibers. Is it clear? So gate control theory is one of the very popular question, So gate control theory itself 10 number question might be coming, but more commonly it comes as a short note, 4 or 5 number. But gate control theory itself can be a long question. I have talked almost 10 minutes with the gate control theory. So you remember the mechanism, you remember the history, you remember who first published it, and you remember the practical applications of gate control theory, clinical applications of the gate control theory. So you have to tell 3 things. One is moving your hand with a touch, simple thing. Second is spinal cord stimulator. Third is TENS. So these are the practical applications of the gate control theory. So what we are discussing? We are discussing pain modulation. Number 1 heading was descending inhibitory pathway. I've discussed in detail. Second heading was gate control theory. Now, two other important areas. One is called the segmental inhibition. What is it? If you are recapitulating our first year physiology class, can you remember that there are two types of neurotransmitters? One is excitatory, another is inhibitory. So excitatory neurotransmitters means the action potentials will be potentiated in the next order neuron, and inhibitory means it will be dampened in the next order neuron. So you have to remember few neurotransmitter names also. What are the excitatory neurotransmitter transmitting pain? So what are these? One is nitrous oxide, second is glutamate, third is substance P, fourth is CGRP, calcitonin gene related polypeptide. Remember these four important excitatory neurotransmitters. And inhibitory neurotransmitters, remember two, GABA and glycine. So now, if inhibitory interneurons are inhibitory neurotransmitters are released and suppressing pain, that is called segmental inhibition. Have you seen? So if there is a second mechanism of spinal cord stimulator, means if you are stimulating electrically, not just gate control theory is there, there is also release of the neurotransmitters which are inhibitory in action, and this is called segmental inhibition. And this segmental inhibition is suppressed in chronic pain. We'll be discussing that in the next class. And the last one is your endogenous chemicals. So there are certain endogenous substance like opioids, like cannabinoids. These can suppress the pain naturally, and that is your fourth kind of pain modulation. So pain modulation could be remembered under four heading. One is descending inhibitory pathway, second is gate control theory, third is segmental inhibition, and fourth is endogenous opioids and cannabinoids which suppress the pain. So just to recapitulate, the four important areas of the pain pathway: transduction, transmission, perception, and modulation. So in the perception, we told few important areas which are not nicely covered. One of the most important area to remember is limbic area. And modulation, mostly not covered in our undergraduate postgraduate studies, but pain modulation is very, very important. That determines how much pain will be felt in the healthy individual. So one thing you have to remember, that the modulation is a feature of a healthy individual. And other thing that I call the amplification, that is the feature of an unhealthy individual. Means if somebody is having the the sensitizations, again I told you sensitization I'll be discussing on the other day. So that is on the heading of the amplification, and that is called sensitization. So I'll be stopping it here, and I'll be asking you the questions. Next day I'll be discussing about the other important areas, the different type. Or Sulay, what is the time exactly? Okay, I can talk another 5-10 minutes to talk about the different types of pain. Or maybe can I take the question answer right now, and the rest part means the classification of the pain and the sensitization I'll be talking on the next day. Is it okay?
Okay, sir.
So let me invite the questions from the audience, so that if there is any doubts, whatever the doubts they are having, we can take care of those doubts.